And I believe you're the only. Is Dr. Alhawshani here as well?
Oh no, he's not here.
Oh, he's not here. Okay. So, okay, welcome.
Hi everyone. Is it okay if I'm just a little bit more mobile? I have restless body syndrome. So my name is Suleiman Furmli, and my counterpart Salman Alhawshani couldn't be here today. He's busy saving lives thousands of miles overseas in the Kingdom of Saudi Arabia. But I'm going to try to fill in for both myself and his big shoes. So our studies on family medicine residents' perception of psychotherapy training, a mixed method study, and really our study, what I hope to convey is sort of a narrative, and it's a narrative of millions of Canadians who are suffering with mental health illness, and the thousands of providers, including yourselves, family physicians, etc., that are here to provide care for them. So just to give you a little bit of background, mental health is a huge epidemic and emergency in most developed nations and around the world. In Canada, 1 in 2 Canadians will experience a mental illness by the age of 40. And I'm sure all of us here in this room have been touched by mental illness, either ourselves or within our family circles, and if not, then for sure within our patient population. Each year, 4,000 Canadians take their own life, and that's an average of 11 suicides a day. The economic burden and mental health is the leading cause of disability in Canada, and the economic burden is outrageous. I can't even imagine $51 billion in my head if I tried to. So our study was really informed by our practice, and I've sort of tried to construct a narrative of what a typical practice day would look like, and I'm sure many of you can relate. And a lot of these presentations, these are the chief complaints and the ages and the genders, but a lot of these relate to mental illness or mental health. And to be quite honest, as family medicine residents and as practitioners, it's so rewarding to be in a position where you can learn people's most intimate details about their life and what's causing them pain. But it's also very burdensome, and it's also very taxing on us. Not because we're experiencing their illness, but because me and Salman, we both felt like we were doing a disservice to our patients because our efforts, we would almost seldom would we see huge improvements in our patients with mental health illness. And we felt like we were unprepared and not doing a good job. So that's really where our frustrations came from. And this was an interesting quote that just kind of, just stabbed me right in the heart, because when I thought about this question that Plato asked 3,000 years ago about the greatest mistake that physicians make, I just thought to myself, I asked myself this question, and I would open that up to everyone else in this room, about how much we've done to correct this mistake, and how much are we doing, and also how can we make things better moving forward? How can we make sure that we don't keep making this mistake for thousands of years to come? And the quote here is, the greatest mistake physicians make is that they attempt to cure the body without attempting to cure the mind. Yet the mind and the body are one and should not be treated separately. And certainly our study today is looking at how we can treat the mind, and as opposed to just the body. And just as recent as 100 years ago, the famous Mayo brothers, who founded the Mayo Clinic in the States, they had a famous quote, which also struck me as very profound, that they found that more than half of our hospital beds are occupied by people with nervous troubles. And they said that the nervous troubles are not because the nerves are damaged, but because of emotions of futility, frustration, anxiety, worry, defeat, and despair. And that was 100 years ago, and that was half of their beds. So imagine what it must be like today. So again, just our observations, we felt that mental health presentations were extremely common. We felt like we were ill-prepared to deal with it and manage it. We found it was difficult for us to even outsource and try to refer patients to get that therapy elsewhere. And because of that, we felt like we were not doing the best job that we could caring for these patients. And moreover, we found it was difficult for us to try to get the training that we wanted to. Bernice can attest to how difficult it was when I was trying to find psychotherapy electives to learn how to do it. But conversely, and here's the hope, was that when I did get that training and I came back in my family medicine practice, I felt like I was much better equipped, and I saw results, and I saw my patients getting better. And so that's what made me and Salman want to think of doing this study across UofT residents. So first of all, what is psychotherapy? Again, kind of a fancy word, really just means talk therapy. That's all. We're just going to leave it a simple definition. It's any kind of therapy, talk-based therapy that's meant to alleviate symptoms and psychological distress in the context of mental illness. And for the purpose of our study, we try to limit, like on our surveys when we ask residents, we just try to limit it between the most common forms of psychotherapy, which include cognitive behavioral therapy, CBT, IPT, supportive psychotherapy, and motivational interviewing. These are probably the most common bread and butter things that we might be most useful for us in the primary care practice. So what's the literature on psychotherapy and in mental health? So according to the CANMAT guidelines, 2016, so this is the Canadian Network of Mood and Anxiety Disorder Treatment guidelines, they recommend psychotherapy as first line for mild to moderate mood symptoms. They found it's as effective as pharmacotherapy, but in my perspective, I think it's much better because it has almost no side effects. It's more empowering and skill building for the patient. It's easier in terms of compliance, right? They don't have to remember to take medications or side effects for medications and they stop taking it, which is a huge issue in mental illness. There's lower risks of relapse, so once they stop taking the medication, they're going to lose the benefits, whereas once they learn the psychotherapy skills, once they're done with you, and the aim with psychotherapy so that once they're done with you, once you're done the therapy, they can take those skills for life, hopefully. And in terms of mental health and psychotherapy studies that show its usage in primary care, there have been a few studies. One in 2005 showed that how common it was, how common mental health illness was in primary care. And the second study showed the cost savings of integrating psychotherapy in primary care to savings of $10 for every $1 spent. So it's really, really useful for us to be able to integrate psychotherapy within primary care. In terms of psychotherapy training for family medicine residents specifically, there's been no studies to date that we could find from our literature research that talks about this. And we did find studies showing training for psychiatry residents in residency for psychotherapy, and that was like less than 10 or less. And we did also find we found one master dissertation that was done just 2 years ago where a family medicine resident interviewed 18 family physicians and asked their opinions about psychotherapy. So these were practicing physicians for a long time, and they found that training was a huge barrier. So what was our research question? How could we investigate this? So we wanted to learn the perspectives of family medicine residents on psychotherapy training with the aim that if there's a gap, we could maybe hopefully fill that gap. So we specified our questions to 3 specific questions. The first one was, do family medicine residents even perceive psychotherapy to be an important skill for us as family doctors or family medicine residents to learn? Secondly, how much training are we getting already, if any? And thirdly, do family medicine residents even have an appetite for learning more psychotherapy? So what was our research approach? So we used both qualitative and quantitative, we used a mixed methods approach, sequential mixed methods approach. So what we did first was we created a qualitative survey to send out to residents. We then took the results from the qualitative survey and we generated some focus group guidelines, so open-ended questions to help explain that data. And then we conducted a focus group discussion to help better elucidate and give us more depth into that data. And then we used the results from both the quantitative and the qualitative to help answer our 3 questions that we just spoke about. All right. In terms of our methods, we got REB approval from the UofT downtown. We used an electronic survey given out through SurveyMonkey. It had 14 qualitative questions and 1 open-ended question. And we used the SPSS to help us analyze some of the chi-square and the bivariate statistics. And then lastly, we used our focus group discussion. We had 1 focus group and 6 residents attending. So what were our results? So in terms of the demographics of who answered our survey, we had about 140 survey respondents, so 140 family medicine residents responded from a total of 316, which gave us a response rate of about 44%. In terms of across the sites, we wanted to make sure that we had good representation, and we did. We had at least 5 residents from each site. I want to give hats off to Markham Sobel for supporting us, being the highest. And in terms of training level, we had equal representation across PGY1 and PGY2. We also wanted to ask residents how many of them had already received have undergone their mental health rotation, 14% had, only 14% hadn't, but the majority, 86% had. Next was we asked how many of them residents had psychotherapy training before starting family medicine residency. Again, to remove that as a confounder, we had 90% had it, and only 10%, approximately 10% had. So our first question, this is probably question number 2. This is question number 1. Is psychotherapy perceived as an important therapy or skill for family medicine residents to learn? So this table we asked residents approximately what percentage of their primary care visits were mental health related, and over 80% of family medicine residents felt that between 20 and 60% of their primary care visits alone were just mental health, which is a significant chunk. We also asked residents, do you feel that psychotherapy is an evidence-based treatment? And 92% agreed that it was. We also asked residents, do you perceive psychotherapy to be an important skill for us to know as being a family physician? And 90% said yes, they believe that this is a skill that all family physicians should know. And in terms of the qualitative analysis, so just asking residents what they thought, they said, some of them said, invaluable for any family doctor. Almost all issues with patients can be addressed at least partially with psychotherapy concepts. I absolutely think psychotherapy training is vital to our residency education. I believe it is a very important part of family medicine practice. It is very difficult for patients to access psychotherapy for mental health needs, which are highly common in family medicine practice. And I believe psychotherapy training to be an essential skill to a primary care practitioner. These are some of the quotes. The second question was, how much training are family medicine residents receiving currently? Again, in terms of this table shows how many hours of didactic training and psychotherapy residents received. So about 90% of residents received less than 5 hours of training in total, and with 40% receiving 0 training in didactic training in psychotherapy. So again, not much training. In terms of hours of clinically supervised psychotherapy, 72%, almost 3/4 of residents said they didn't get any training whatsoever or any supervised training in psychotherapy. This is a chi-square analysis. We looked at the link between completing their mental health block and receiving hours of didactic therapy, and we saw there was no association. So doing your mental health block did not make it any more likely that you're going to get hours of didactic training in psychotherapy. Similarly, we looked at the link between completing their mental health block and getting clinically supervised supervision of psychotherapy, and again, there was no linking. So doing your mental health rotation did not mean that you would get any clinically supervised training. So in terms of what residents thought about how much training we're getting, residents said we are vastly undertrained in the family medicine residency program at the University of Toronto in this invaluable skill for a general practitioner. I believe overall it is a significant gap in our training that we do not otherwise have supervised psychotherapy training sessions, 0 to no training in this. So it's kind of an overall theme that we noticed. Lastly, do family medicine residents have an appetite for learning psychotherapy? So we just asked this question point blank, and 75% of residents said they are motivated to learn psychotherapy. We looked at the link between, if you do your mental health rotation, are you more likely to want to learn psychotherapy? And we found there was a link. So perhaps just being exposed to mental health patients is enough to make you want to learn psychotherapy. But however, we also learned that there was the motivation to learn psychotherapy was not associated with hours of didactic training. So, so just because someone teaches you in a lecture like this about psychotherapy training did not mean that you'd be more willing to learn psychotherapy. So kind of speaks to maybe didactic training is not the best way to get this message across. In terms of what residents thought about this, I'm 100% beyond 100%, I am beyond 100% on board with adding formal didactic psychotherapy training to the family medicine residency. I believe I'm doing a disservice to patients with mental health issues otherwise. Considering the high prevalence of mental health issues, I think having more scheduled training in psychotherapy would be beneficial for both patients and physicians. I would love more training. It would help so much, especially because I have lots of patients who cannot afford outside therapy, etc., etc. In terms of our conclusions, so here are the 3 questions, and here are our conclusions. So, is psychotherapy perceived as an important therapy skill for family medicines to learn? A resounding yes. Question number 2, how much training are we getting? Very minimal. And number 3, do family medicine residents have an appetite? We found that yes, we do. I'm going to skip this slide due to time, but basically it talked about that didactic training is probably not the best way to teach family medicine residents this topic if we do go about addressing this gap. In terms of our study strengths, we had a good response rate for a survey. We used mixed methods, which were added to our study design. It was pretty simple and it was novel. It has never been done before. In terms of our weaknesses, we can't really generalize our data to all of Canada, which was our initial intent, but we hope to do a further studies, hopefully, and replicate this across Canada if we can. We did not stratify results by teaching site to account for curriculum differences. We also did not complete any multivariate analysis to look for other confounders. All the data in our study is subjective, so this is family medicine residents just putting what they thought as opposed to objective data. And lastly, our focus group number was limited by time and resources. And just in terms of moving forward, this is just the beginning for us. Both me and Salman are passionate about hopefully taking this forward and trying to meet this gap that our study sort of elucidated. So our abstract for our studies are already been accepted to 3 psychotherapy conferences, which we look forward to attending and seeing what else is happening in this field. We're also looking, again, as I mentioned, to conduct the study across Canada if we can. And also doing some key informing interviews. We've already established linkages with curriculum leaders at UofT in general and in psychotherapy to try and figure out how we can fill this gap. And also, honestly, working to lobby the government to try and invest in making training more accessible and making mental health more accessible for family physicians and allied health staff. Thank you for listening.
Thank you again for an excellent presentation. So, any questions, Maya?
Yeah, so there's some, our sense is that it's probably the same, if not worse, in other parts of the country. So actually in BC, one of our collaborators, he actually published an article about this same study on psychiatry residents in BC. And when we had approached him, he said, this is really weird that you guys are asking me this in family medicine because family medicine doctors here can't even bill for psychotherapy. That's what he told me. I haven't verified to know for sure, but we imagine it's probably the same across the country because we haven't seen any initiatives promoting this in other schools, but there could be.
So I actually attended Western. We were a block system, so we had 9 sessions that involved using therapists and social work and team meetings with psychiatry as well.
Okay.
So it would be helpful to know what's going on in other schools as well, because if there's things that are working, then you don't necessarily need to make them, But it's helpful to know because I think you're kind of starting from the bottom up.
Yeah, that sounds great. And actually, we do have a similar program to what you mentioned at Western here too. So it's not that it doesn't exist; it's that it's very limited number. So at Mount Sinai, there's also a longitudinal program where some residents can sign up for, but their capacity is very limited. So we had one girl in our focus group tell us it was an amazing program, and she felt competent to offering psychotherapy to her patients just from that program alone. And she got it was really rigorous. Like they got supervised feedback, instant feedback. But it's just that the volume is not there. So I would love to speak with you more about how much capacity they're able to build at Western. Like, were they able to do this for all residents, or oh, it was a requirement? Okay, yeah. So that's a great suggestion.
Sorry. So every time I go to a meeting downtown as post-grad director, there's a agenda item saying, if you know anybody who would be willing to teach the residents, please let us know. So it's you choose from the staff, it's the faculty, they're trying.
Yeah.
But
Sounds good. Yeah. Any other questions?
Yeah, so I know you had a little bit of a mention on like the didactic aspect and formalized like clinically supervised training. So I know we had gotten emails for applications for like the second year resident, like an R2, the counseling kind of elective. Do you know whether or not like that is where I guess people who did receive the supervision like stuff, like is that where they got that from? Or like, you know, and I guess it's more like a program thing, but like how available that is to residents, because I've heard some stuff about like only a certain number of residents can join like that counseling longitudinal program, even though like I think even amongst us like quite a few people were really interested in doing it. So
Yeah, that's a great question. So from our study in the focus groups, we identified two programs. That one was the Mount Sinai program, the other one was the counseling skills program. The counseling skills program, the residents that gave us feedback said that the ones who did it said it was really great. The ones who wanted to do it but couldn't said that it was difficult for them to fit it into their schedule because it was basically extracurricular time that you're doing to do that, as opposed to it being integrated or you getting credit for it within your normal curriculum. So and then the other side, the Sinai one is only for Sinai residents. Yeah. So that's the issue. It's not that it doesn't exist. It's just that it's not at the level where everyone can benefit from it and offer it seriously in a rigorous way for their patients. Any other questions? I thought I saw a hand over there. Hello.
I was going to say, with PMA programs for practitioners, like family practitioners, not like they network with those, but like they have I think it would be like a validated program that are something.
Yeah, absolutely. So that we're trying to make those network with all the existing curriculum people who are teaching it, and all we want to do is try to take those programs and build it into our residency, so that it's not we're doing this as an extracurricular thing. We're doing this as a within curricular thing. Yeah. Thank you so much. Thanks everyone for listening.
Next presenter is Dr. Albert Monaro and James Gibb. The topic is